Hello and welcome to the Academy of Emergency Ultrasound's ultrasound-guided central venous cannulation presentation. My name is Jordan Tozer, and thanks to the help of Drs. Edwards, Moore, and Taylor, we're bringing this presentation to you today. All right, so what are the objectives of this talk? We are going to discuss the indications, contraindications, and some alternatives to central line placement. We will review the central venous access kit and the kit's key components. We will discuss the preparation. We will discuss the various locations, including internal jugular, femoral, and subclavian veins, and the benefits and drawbacks of each location. The meat of the talk will be a discussion on the techniques of placement. We will then discuss the confirmation of placement, and finally, the pearls and pitfalls of central line placement. Okay, so let's talk about the indications for central line placement. Traditionally, central lines have been placed to avoid venous damage during administration of caustic medications, to obtain access for emergent hemodialysis, to obtain access for transvenous pacing, to administer vasopressors in hemodynamically unstable patients, and because there was no other way to obtain access in the patient. Today's landscape, with the widespread use of ultrasound for obtaining traditionally difficult to reach peripheral veins, has meant that central line placement for inability to obtain other access has become much less prevalent. And finally, for the situation where vasopressors are needed in the short term, peripheral vasopressor administration has become a viable alternative. So consider those two things before placing your central line for those indications. Let's review the contraindications for this procedure. There really are no absolute contraindications. And if your patient is already coding, the relative contraindications become even less important. But remember, they include coagulopathy, such as the use of blood thinners or severe thrombocytopenia, infection overlying the site of choice, history of surgery or other manipulation at the site of choice, such as breast cancer surgery or lymph node removal, and finally, trauma at the site. There are several alternatives to central line placement, depending on the indication. Those include peripherally inserted ultrasound-guided IVs using longer catheters. These are used to access veins that are deeper or harder to find from a traditional landmark or palpation technique. IO can certainly be used, especially if your patient is coding or pericode, as a very quick alternative to central line access. And finally, depending on your institution, midline or peripherally inserted central catheters are a viable option if the indication is not emergent. Okay, there are some complications to consider or to be mindful of before your central line is placed. And being mindful of these complications can help you avoid them during your placement procedure. Arterial puncture, bleeding or hematoma, pneumothorax, especially if the central line is being placed in the internal jugular or subclavian veins, thrombosis or clot, which usually follows in the days after central line placement, infection, and much more rare nerve injury. So let's go over the kit. Familiarize yourself with your institution's central line access. They will all be different. Some kits include a mask and gown. Some kits include sterile covers, lidocaine, flushes, and everything you need. However, some kits are more bare bones and only contain the key components. So let's go over those now. Your key components include your initial venous access needle, which is a long, large bore needle that you can pass a guide wire through, your guide wire, your triple lumen or other central line that you will be leaving in the patient. You will also have a dilator and a scalpel to make an incision. You should also have suture material to secure the line in place once it has been placed. The preparation for this procedure is key to successful outcome. So let's briefly review ultrasound vessel anatomy. Veins are going to be thin-walled structures that are easily compressible with gentle to light pressure. In the normal state, they will have no pulsatile flow associated with them under color. Arteries, on the other hand, are usually thick-walled structures that are round and not irregular and are non-compressible except for under the most extreme amount of pressure. Arteries will demonstrate pulsatile flow, and those flows will generally be higher as detected in any sort of Doppler. Pre-scanning is an imperative preparation step prior to initiation of your central line placement. Always use the ultrasound to determine where your vessel of choice runs, to find the best location for access, to localize the vessel in relation to other landmarks, and to evaluate for thrombus. There is nothing worse than getting your patient sterilized, draped, getting gloved and gowned and prepped, only to find that your patient has a big clot in the vessel and you got to start all over. Positioning is another key step to ensuring a successful central line placement procedure. You want everything as ergonomic as possible. Make sure the bed height is appropriate. Make sure that your machine is easily accessible and easy to see without twisting, turning, or moving too much. And always remember to have an assistant. Okay, let's talk about locations. The internal jugular vein is traditionally the most accessed central venous catheter site. It can be found via the landmark technique between the two heads of the sternocleidomastoid muscle and above the clavicle. Using ultrasound, you can start in that location and slide up the neck. Ideally, you will find the internal jugular at its most adjacent site to the carotid rather than directly on top. This will prevent a back wall needle access through the internal jugular and into the carotid. The femoral vein can be found below the inguinal ligament and should be accessed proximal to the confluence of the deep and superficial femoral veins. Traditionally, this is considered a site that's more prone to infection in the post-placement time period. However, using standard sterile technique, that is proven to no longer be the case. This is my preferred access site, especially due to patient comfort in the awake patient, but it is also more easily accessed in most patients. The subclavian vein is not traditionally thought of as accessible via ultrasound guidance. However, this may be a viable alternative in a select number of patients. Through the infraclavicular approach, the ultrasound probe is placed with the marker towards the patient head. And this will allow you to see the subclavian vein in cross-section just below the clavicle. In this cross-sectional view of the subclavian vein, it is critical to note the relationship of the lung to the vein and mark the distance between the skin and the lung so that you can be mindful of needle depth when performing this procedure. Once you have identified the clavicle, the vein, and the lung, you can go ahead and begin this procedure. It is important to note that sometimes the artery will be hidden beneath the clavicle. Other times it will be easily visible and you can distinguish between the two with compression. However, this is not always possible on all patients. So let's move on to the meat of the procedure, which is finding your needle under ultrasound and guiding it into the vein. Once you have your vessel localized to the center of your screen, you're ready to begin the needle entry procedure. Place the needle with the bevel up at a 45-degree angle, just adjacent to the ultrasound probe. Enter the skin and find the needle within the beam of the ultrasound. There are two ways to advance the needle. Number one, you can advance the needle and the probe together so that your needle tip always remains in view. Or you can do a stepwise approach where you advance your ultrasound, then advance your needle into the beam. Once you have placed the needle successfully in to the center of the vessel, as shown on your ultrasound, you can lower the angle of your needle and aspirate, ensuring that that movement does not dislodge the needle from the vessel. Once you have achieved successful aspiration, you can place the ultrasound probe aside, maintaining sterility with it, and hold positioning on the needle while removing your syringe. With the needle anchored in the same position and angle as during the aspiration procedure, you're now ready to insert the guide wire. This can be done in one of two ways. Traditionally, the guide wire will be inserted directly through the needle and into the vessel body. However, if you have one of the unique syringes shown in the picture here, you can actually pass the guide wire directly through the syringe, eliminating the need for the removal step, which can sometimes cause dislodgement of needle positioning. Once your guide wire is in the vessel, you can remove your needle and the guide wire will remain in place. This is known as the Seldinger technique. At this point in time, part of the confirmation procedure involves ensuring that your guide wire is in the vein and not the soft tissue or artery before the dilation step and before the placement of your catheter. Once you have confirmed venous placement of your guide wire, you can move to the incision and dilation step. For the incision, you should use an 11 blade angled downward to make a small incision adjacent to the guide wire, enlarging the opening through the skin for the dilator to pass. Once that has been done, you will put your dilator over your guide wire, maintaining a grip on the guide wire, and gently but firmly towards the distal end of the dilator, start to insert that through the skin, through the soft tissue, and into the vein. You only need to insert enough of that dilator to reach the vein so that your catheter can then subsequently move easily through the soft tissues. Once that has been done, remove the dilator, maintaining a grip on the guide wire. This can be a bloody step, so make sure to have some gauze ready so that you can maintain visualization of the area. Once you have dilated, you are ready to place your central venous catheter over your guide wire. Remember during this phase to maintain a tight grip on the guide wire at all times. Use firm but gentle pressure to place your catheter to the appropriate depth. Always remember to fully remove your guide wire at the end of this step. The double black line at the end of most standard triple lumen catheters marks 20 centimeters. Keeping this chart in mind will help you with depth of placement on a standard height patient. Once your catheter is placed, use your hospital-approved sterile cover device. Place your hospital-approved caps. Confirm that all your ports draw and flush them, clamp them, and secure with your suture. Finally, apply your transparent dressing. The next step is to confirm the location of your central venous catheter. Let's discuss central line confirmation with ultrasound. First, let's review chest X-ray confirmation of central venous catheter placement. This is still a viable approach. Here you'll note that the right IJ central line is located near the level of the right atrium and SVC junction, which is an ideal location. Ultrasound confirmation of central venous catheter placement has been proven to have advantages over your traditional chest X-ray confirmation. First, it's faster. You don't have to put it in order and wait for anyone to get there. You can simply confirm the placement after the procedure is done. And it has been shown to be accurate. A recent meta-analysis showed a pooled positive and negative likelihood ratio of detecting malposition by ultrasound was 31 and 0.25 respectively. In order to do this, we need to know what the rapid atrial swirl sign is. This catheter confirmation for lines placed above the diaphragm, that is internal jugular and subclavian veins, is a three-step approach. Step number one, as we've already discussed, is confirming that your guide wire is in the vein prior to any dilation or catheter placement. Number two, for those above the diaphragm central lines, we need to make sure that we have not caused a pneumothorax. We can simply look for lung sliding as shown here in the middle video. And finally, as previously mentioned, we need to do a rapid atrial swirl sign test. This involves flushing your central port of your catheter with a small amount of saline and detecting the bubbles from that flush in the right atrium. A confirmatory rapid atrial swirl sign will have those bubbles appear within the right atrium in less than 2 seconds. A delay in bubble placement could indicate a catheter malposition, and an absence of bubble placement could indicate that your central catheter is either in an artery or a soft tissue. Confirming the rapid atrial swirl sign should be done using a subxiphoid or apical four-chamber view. Occasionally, if your view is suboptimal, you may have difficulty detecting those microbubbles created by your saline flush. One method to alleviate this is to use a three-way stopcock and 2 syringes to create an agitated saline, and flushing this can be much easier to detect. So let's discuss some pearls and pitfalls for central line placement. Some of these we've already hinted at. First and foremost, do you really need it? No procedure is without risk. So if there are alternatives, I would consider those before placing a central line. Is peripheral access easily obtainable and adequate for your patient's needs? If your patient only requires short-term vasopressors, is a central line needed? Remember to always pre-scan. Patients have various anatomy, patient has various pathologies. Occasionally you will find a vessel that is inadequate or hidden behind an artery, and occasionally you may find that your vessel has thrombosed and will be an inadequate site for access. Why not use your femoral line? It is just as clean if full sterile procedures are being used, and in most patients is a more easily accessed and more tolerable location than an IJ or subclavian placement. When placing your central venous catheter, make sure you know where your needle tip is at all times. This is the key to your procedure. If you have lost your needle tip, don't continue to advance your needle. Hold, come back until you find your needle tip within your ultrasound beam, or remove the needle altogether if you are lost. What happens if you puncture your artery? If you puncture an artery, such as the carotid, before you have dilated or placed any other materials, simply pull out and hold pressure. At that point in time, depending on the amount of extravasation that's caused, you should consider using an alternative site for future central venous catheter placement. If, however, you have gone through the steps of your central line placement procedure and either dilated or placed a central venous catheter, at that point in time, you want to confirm that it is indeed arterial using either ultrasound, manometry, or waveform analysis, and call your consultants, either vascular or IR, depending on your institution. Briefly, here are some references. Thank you for your attention and good luck with your central line placement.